let's dive right in. Today, we're taking a clinical masterclass in the complex protocols for treating hydrocephalus. If you're looking to understand the exact step-by-step methodologies without having to slog through a massive medical textbook, you are exactly where you need to be. We're going to break down every single crucial detail from the clinical literature so you won't miss a thing. We're going to unfold this explainer systematically. We'll start with the treatment overview and diuretics, move into counteracting acidosis and monitoring, then discuss spinal taps as a treatment. After that, we'll cover surgical goals and endoscopy, shunting and obstruction removal, and finally, wrap up with the fascinating history of choroid plexixectomy. All right, let's jump straight into Section 1, treatment overview and diuretics. First things first, we have to establish that hydrocephalus is primarily a surgically treated condition. But medical interventions like diuretics act as a highly critical bridge. You can't just hand these out to anyone, though. They're specifically used in premature infants who have bloody CSF, acting as a temporizing measure when there's no active hydrocephalus yet. Now, what's really interesting is that you can see about a 50% success rate in strictly qualified patients, but they have to meet all the criteria. They must be under 1 year old, have completely stable vital signs, totally normal renal function, and absolutely no symptoms of elevated intracranial pressure, meaning no apnea, lethargy, or vomiting. We cannot skip any of those boxes. Let's get into the exact pharmacological regimen step by step. Step 1 relies on acetazolamide, which is a carbonic anhydrase inhibitor. The secret here is a meticulous, gradual step up. You start at 25 milligrams per kilogram per day, given orally and divided 3 times a day. Then you increase that dosage by 25 milligrams per kilogram every single day until you hit the absolute maximum of 100 milligrams per kilogram per day. Now here's the crucial timing factor you cannot miss. Step 2 is not sequential. The protocol actually mandates starting furosemide simultaneously. The dosage for this is 1 milligram per kilogram per day, administered orally and also divided 3 times a day. Moving right along to Section 2, counteracting acidosis and monitoring. Altering fluid dynamics, this aggressively requires a really intense metabolic balancing act. Step 3 is all about counteracting the resulting acidosis, and we do this using tricitrate, which is commonly known as polycitra. You absolutely must memorize this precise starting dose and molecular composition. It's 4 milliliters per kilogram per day divided 4 times a day. And as you can see mapped out here, each milliliter packs 2 milliequivalents of bicarbonate, 1 of potassium, and 1 of sodium. The key to making this work is highly dynamic, daily adjustment based on serial electrolyte measurements. Your main objective is maintaining serum bicarbonate above 18 milliequivalents per liter, but you've got to be ready to pivot instantly. If you see serum potassium dropping, you swap over to polycitric A, which gives you 2 milliequivalents of potassium per mil, but 0 sodium. On the flip side, if serum sodium drops, you change straight to sodium bicarbonate. It's a very active, hands-on monitoring process. And Step 4 requires intense clinical vigilance. You literally cannot afford to skip monitoring for acetazolamide side effects. The clinical texts explicitly warn us to watch for overall electrolyte imbalance, lethargy, tachypnea, diarrhea, and notably, paresthesias, which was that very distinct tingling feeling in the fingertips. When we look at the long-term timeline, the rules are incredibly strict. Every single week, you must perform an ultrasound or a CT scan. If you spot progressive ventriculomegaly, you stop the medical therapy immediately and insert a ventricular shunt. But if the patient remains stable, you maintain the therapy for a full 6-month trial period. After those 6 months, you carefully taper the dosage over 2 to 4 weeks. And if progressive hydrocephalus rears its head again, you resume the treatment for another 3 to 4 months. All right, Section 3, spinal taps as treatment. Let's shift our focus from pharmacology to mechanical temporizing approaches. It's absolutely vital to differentiate exactly how and when we use taps. Hydrocephalus that occurs after an intraventricular hemorrhage might just be transient. In those specific cases, serial taps, meaning either ventricular or lumbar punctures, can temporarily relieve pressure until normal resorption resumes. However, there is a hard and fast rule. Lumbar punctures can only be performed for communicating hydrocephalus. If the fluid pathways are obstructed and not communicating, an LP is completely off the table. Now, there's a critical threshold number you need to watch for, 100 milligrams per deciliter. If the protein content of the CSF drops below this mark and normal resorption still hasn't kicked back in, spontaneous resorption is highly unlikely anytime soon. The reality here is that a surgical shunt will almost certainly become necessary. Which brings us nicely to Section 4, surgical goals and endoscopy. Before we get into the surgical mechanics, we have to completely reset our clinical expectations. I want you to remember this quote directly from the literature. Normal-sized ventricles is not the goal of therapy. It sounds totally counterintuitive, right? But the texts are very clear. Some children simply have aposity or a lack of brain tissue. Shrinking their ventricles down to a textbook normal size is simply not the target we're aiming for. So if we aren't chasing normal-sized ventricles, what are we doing? Our 3 strict endpoints are achieving optimum neurologic function, maintaining normal intracranial pressure, which is practically a prerequisite for that optimal function anyway, and finally, ensuring a good cosmetic result for the patient. The first major surgical option in the literature is the third ventriculostomy. This is a procedure where a surgeon creates an opening directly in the floor of the third ventricle, allowing the CSF to totally bypass an obstruction. And today, modern medicine overwhelmingly prefers to perform this method endoscopically. Let's look at Section 5, shunting and obstruction removal. Beyond the ventriculostomy, we have shunting, and there definitely isn't a one-size-fits-all approach here. The surgical arsenal includes 4 main types, chosen based on the patient's exact anatomy and needs. We have the VP, or ventriculoperitoneal shunt, the VA, or ventriculoatrial shunt, the ventriculopleural shunt, and finally the LP, or lumboperitoneal shunt. Now, a very logical question usually comes up right about now. Why not just remove the blockage itself? Well, while eliminating an obstruction, like trying to open a stenosed sylvian aqueduct, might seem like the most direct fix, it actually carries much higher morbidity and far lower success rates than simple CSF diversion with a shunt. There is one massive exception, though: tumors. If a tumor is causing the obstruction, removing it is absolutely the preferred route. Finally, let's turn to Section 6, the history of choroid plexectomy. This is a pretty fascinating and honestly pretty dangerous slice of medical history. Tracing its roots all the way back to 1910, endoscopic choroid plexus coagulation was originally described over a century ago. It was later documented by Walter Dandy in 1918 specifically for treating communicating hydrocephalus. It fell out of favor for a long time, but amazingly, this endoscopic method has actually seen a modern resurrection. But we have to understand its severe physiological limitations. The procedure reduces but absolutely does not totally halt CSF production. Why? Because the choroid plexus isn't the only source. CSF is also secreted by the ependymal lining of the ventricles and the dural sleeves of spinal nerve roots. Historically, performing this as an open surgery carried massive mortality rates. This was largely due to a lethal complication where air ended up replacing the CSF during the open procedure. We've unpacked every granular detail of these protocols, from those highly fatal open surgeries in the 1910s, straight through to today's meticulously balanced diuretic cocktails and advanced endoscopic shunts. And looking at all this leaves us with a pretty profound question. As our understanding of complex brain physiology deepens, what future medical breakthroughs might finally render these lifelong surgical interventions completely obsolete? Keep questioning the science, and thanks for joining me for this explainer.